My name is Stephanie Hadley, and I'm a third-year medical student. I'm here to talk about delirium in the pediatric ICU. So first, what exactly is delirium? The DSM-5 defines delirium as a disturbance of attention or awareness from baseline that develops acutely and fluctuates in severity, along with an additional disturbance in cognition that cannot be explained by a pre-existing neurocognitive disorder and is a consequence of a medical condition. So why should we care about delirium? Well, delirium is extremely common in the pediatric intensive care units, occurring in 30% of all patients in the PICU. Younger kids are at an even higher risk. Over 50% of PICU patients between the ages of 6 months and 2 years become delirious at some point during their stay. This discovery about the high prevalence of delirium in the PICU is still recent, so long-term outcomes have not been very well studied. What we do know is that children who develop delirium are more likely to have longer lengths of stay in both the ICU and the hospital, and have an 85% higher PICU cost. They also experience higher in-hospital mortality rates and are more likely to have longer school absences following hospital discharge. Although this implies that delirium likely impacts long-term cognition in some capacity, researchers are still studying the lasting effects. So now that we've talked about the importance of delirium, let's talk about why it happens. Normally, there's a careful balance between excitatory and inhibitory neurotransmitters in the brain. Excitatory neurotransmitters include dopamine, glutamate, and serotonin, while inhibitory neurotransmitters include GABA and acetylcholine. Serious illnesses can alter the release, synthesis, or degradation of these neurotransmitters or affect the expression of their receptors. Disrupting this balance in either direction can result in delirium. Now, when most people hear delirium, they think of little old ladies who get an infection and start saying funny things. But what does delirium look like in kids? This can vary dramatically based on which direction that neurotransmitter balance gets tipped. There are two main forms of delirium, hypoactive and hyperactive. Hypoactive delirium is much more prevalent in children and commonly occurs from excessive acetylcholine or GABA receptor activity, such as from the administration of benzodiazepines. These children may appear apathetic or uninterested in their environment, or they may display signs of psychomotor retardation or a depressed level of consciousness. This form of delirium is frequently more difficult to detect, since the patients aren't typically causing any problems for the team. On the other hand, hyperactive delirium frequently results from too much dopaminergic stimulation or cholinergic blockage. These kids may present as agitated, restless, or emotionally unstable, and they may even show signs of psychosis. It's also possible to display features of both hypoactive and hyperactive delirium in a mixed phenotype. There are a few important signs of delirium that I'd like to point out that are more common in kids than adults. These include purposeless actions, sleep-wake cycle disturbances, labile affects, inconsolability, and autonomic instability. Be sure to look out for these and recognize that children displaying these signs may need to be screened for delirium. Speaking of screening for delirium can be very tricky to detect in pediatric populations. One of the main reasons why detection is so difficult is because the risk factors for delirium in children have not been very well studied. This makes it difficult to identify high-risk populations upon admission and track their mental status more carefully. In addition, kids have dramatically different baseline cognitive and language abilities across the developmental spectrum. This can make it harder to recognize acute changes, especially if the physician is not familiar with the child's baseline state. In fact, this challenge is similarly reflected in screening for delirium in older adults with dementia. Distinguishing between cognitive impairment secondary to dementia in older adults and fluctuating mental status changes caused by delirium can be extremely challenging. This variability in presentation has also posed a challenge for developing a screening tool for delirium in the pediatric population. To combat this, delirium experts here at Vanderbilt have developed two separate tools, the PCAM ICU, and the PSCAM ICU to allow for more age-appropriate screening. The Pediatric CAM ICU is a valid and reliable tool for detecting delirium in children at least 5 years of age in pediatric ICUs. It has been shown to be 83% sensitive and 99% specific for the diagnosis of delirium and can be used for children on or off mechanical ventilation. This tool is very similar to the CAM ICU for adults, testing the 4 cardinal features of delirium: acute changes in mental status, inattention, altered level of consciousness, and disorganized thinking. With the exception of having more kid-friendly questions to screen for disorganized thinking, this tool very closely mimics its adult counterpart. While the PCAM ICU is a great tool for children over the age of 5, the majority of PICU patients are between 6 months and 5 years of age. For this population, a more developmentally appropriate assessment was needed, so the pediatric CAM ICU was further adapted into the preschool CAM ICU. This creative method incorporates tracking cards, looking in mirrors, and responding to visual and verbal stimuli to evaluate for inattention. It also considers behavioral changes such as inconsolability and unawareness of surroundings or parents as indicators of a disorganized brain. This tool has similarly high sensitivity and specificity in identifying delirium in this tricky population. So by now we've talked about what delirium is, why it happens, and how to detect it. But what steps can we take to help prevent it from developing in the first place? One of the traditional thoughts surrounding the management of children in the PICU was that heavy sedation and bed rest should be utilized to ensure kids don't remember their stay in the ICU. Now that we're learning more about the effects of delirium on long-term development, however, we've realized that this strategy may cause more harm than good. Instead of relying on heavy sedation, non-pharmacologic interventions, such as involving family in a child's care and filling the room with familiar objects, pictures, and toys, significantly decreases anxiety and the prevalence of delirium. Trying to keep a daily routine is also important in the prevention of delirium, especially in children with autism spectrum disorder. Child Life is an amazing resource, and consulting them early on in a child's PICU course can make a big difference in preventing delirium. Finally, one of the most important contributing factors to the development of delirium is medication usage. Medications such as benzodiazepines, anti-epileptics, and anticholinergics have been associated with a significantly higher likelihood of developing delirium in children. In fact, a recent study performed at Vanderbilt revealed that benzodiazepine exposure was the sole independent predictor for the development of delirium the day following administration, with an odds ratio of 2.83. This is an extremely important finding given that up to 90% of mechanically ventilated infants and children are managed with continuous sedation, often in the form of midazolam. Benzodiazepines affect the developing brain differently than the fully developed adult brains. Drug activity at the NMDA and GABA receptors has been shown to produce apoptotic and neurodegenerative changes that are associated with both immediate neuroanatomical consequences as well as long-lasting or possibly even permanent effects on speech, language, and cognition. The FDA published a drug safety communication on this topic in 2014, advising that prolonged, defined as longer than 3 hours, or repeated use of general anesthetics and sedatives, including propofol, ketamine, and benzodiazepines, be avoided in children less than 3 years of age and pregnant women in their 3rd trimester due to their effect on the developing brain. While further research is still being conducted on the best alternatives to benzodiazepines in children, thinking twice before initiating a sedative could help prevent the development of delirium in kids. In summary, delirium is a highly prevalent and under-recognized condition in the pediatric ICU. While the exact outcomes of pediatric delirium are still being studied, it is evident that delirium lengthens stay in the ICU, increases hospital costs, and has long-term cognitive consequences. Luckily, the PCAM ICU and the PSCAM ICU are effective tools in screening for delirium, and they should be utilized for all pediatric patients in the ICU. Finally, members of the care team should take both pharmacologic and non-pharmacologic steps towards decreasing the risk of developing delirium. Hopefully, you've learned a little something about delirium in the pediatric ICU population. Thank you for watching my video.